When we think about pain management, it's tempting to imagine that the goal is simply to eliminate pain altogether, as if pain were a number to be reduced to zero. Historically, much of modern medicine pursued that aim, with opioids treated as the most direct route to relief. Yet experience has shown that the relentless pursuit of total elimination often leads to new suffering, oversedation, dependency, and a profound sense of disempowerment in patients who feel like passive recipients of care. Marion reminds us that nursing is more complex than that. Her middle-range theory reframes pain management not as a battle against pain alone, but as the pursuit of balance between analgesia and side effects. Balance means that pain must be relieved, but never at the cost of overwhelming side effects. It also means that the patient's own perception of care, whether they trust the process, whether they feel heard, whether they are satisfied, matters just as much as the pharmacology itself. This perspective reflects a broader shift in nursing toward holistic, patient-centered practice, where the subjective experience is as essential as the measurable clinical outcome. Think of a post-surgical patient who is groggy and nauseated from opioids. Their pain may be lessened, but the side effects undermine their sense of safety and satisfaction. In Good's framework, this is imbalance. True balance is a dynamic state, one that differs from patient to patient, where pain relief is sufficient, side effects are tolerable, and the patient feels included and respected. She describes this as the interaction of three domains: pain addressed through multimodal intervention, side effects managed through attentive care, and satisfaction enhanced through patient participation. Good grounds her theory in three propositions, one for each domain. First, she argues that multimodal intervention produces pain relief. By combining opioids with pharmacologic adjuvants and non-pharmacologic methods, nurses can reduce the overall burden of pain while avoiding over-reliance on any single medication. The product here is analgesic influence, a broader, safer, more sustainable way of relieving pain. Second, she proposes that attentive care manages side effects. Monitoring, goal setting, and timely adjustments keep adverse effects at a tolerable level. In practice, this is what nurses do every day, checking whether a patient is too sedated, intervening when nausea becomes intolerable, and adjusting regimens in real time. The outcome is a counterbalance that prevents therapy from tipping out of control. Third, she insists that patient participation secures satisfaction. Education, expectation setting, and shared decision-making mean patients see their care as trustworthy and fair. A patient who knows that we aim for manageable pain, not total elimination, will be less distressed when some pain remains. The outcome here is participation, a cooperative bond between patient and nurse. Taken together, these propositions explain how balance emerges not from a single intervention, but from a dynamic equilibrium maintained by both nursing action and patient input. Good emphasizes that pain relief should never rely on a single medication. Instead, she calls for a multimodal approach. Opioids are still central. They are the strongest analgesics we have. But they should be supported by pharmacologic adjuvants such as non-steroidal anti-inflammatory drugs or local anesthetics. These adjuvants reduce inflammation, blunt transmission of pain, and allow opioids to be used at lower doses. The third leg of the triad is non-pharmacologic methods. Relaxation, music, imagery, and behavioral strategies don't look like powerful painkillers on the surface, but when combined with drugs, they make a measurable difference. For example, a patient listening to calming music while practicing deep breathing can often tolerate a lower dose of opioid, which means fewer side effects down the line. When all three are combined, they produce an emergent analgesic effect greater than the sum of the parts. Good devoted much of her research to these non-pharmacologic adjuvants. Let's consider 5 of them in more detail: relaxation, music, distraction, reframing, and comfort. Relaxation techniques ask the patient to focus on slow breathing or guided imagery. The active inference is simple. I am safe, I can release tension. This produces real physiological effects. Heart rate slows, muscles loosen, stress hormones decline. The experience of pain shifts from urgent to tolerable. Music therapy engages attention in a different way. A patient listening to favorite songs after surgery finds their heart rate and breathing unconsciously aligning to the rhythm. Cortisol drops, mood lifts, and pain feels less overwhelming. It's not the notes themselves, but the whole system of engagement, attention, body response, and emotional change that produces relief. Imagery and distraction use mental construction to compete with pain. A patient imagining themselves walking on a beach or focusing on a puzzle diverts cortical resources away from pain processing. The body relaxes, and the patient experiences pain as background noise rather than the dominant sensation. Cognitive behavioral coping is about reframing meaning. A patient who tells themselves, "This pain is temporary, I can manage it," experiences a drop in stress physiology and gains resilience. Finally, physical comfort measures such as heat, cold, massage, or positioning work through immediate sensory contrast. A warm compress relaxes muscles, altered nerve conduction dulls pain signals, and the patient interprets the new sensation as soothing. Relief is often immediate, and the patient feels empowered to request or repeat the measure. Across all of these methods, the same triad operates: active inference, physiological reaction, and qualitative change in experience. These are not luxuries but integral elements of multimodal intervention, allowing nurses to broaden analgesic influence without adding pharmacologic burden. While multimodal intervention expands the reach of analgesia, it also introduces risks. Every medication and every measure carries potential side effects. Good, therefore, stresses the importance of attentive care as the safeguard. Attentive care means constant vigilance, measuring both pain relief and side effects, setting clear goals for what is acceptable, and adjusting when therapy strays off course. Imagine a patient who is comfortable but so sedated they can't stay awake to eat or participate in physical therapy. Pain relief alone would look successful, but attentive care recognizes the imbalance and intervenes, perhaps reducing the opioid dose, adding an NSAID, or scheduling rest breaks. The emergent product is counterbalance, a dynamic equilibrium that protects both relief and safety. The third domain is satisfaction, and here, Good places responsibility on the nurse to foster genuine patient participation. Participation begins with the patient's own experiences and beliefs. A patient with a long history of untreated pain may distrust the promise of relief. Others may come from cultural contexts where stoicism is valued. Education helps bridge these gaps, explaining available options, side effects, and the goals of therapy. Expectation setting then completes the triad, framing what is realistic and achievable. A patient who's told, "We can take your pain away entirely," is almost certain to be disappointed. But if instead they hear, "Our goal is to keep your pain at a manageable level so you can rest and recover," they'll probably judge the same level of pain as tolerable. The emergent product here is participation, a cooperative relationship built on trust, cooperation, and respect. When participation breaks down, even technically excellent care can leave the patient dissatisfied. Now let's bring the three domains together. Each one produces its own emergent product. Multimodal intervention gives us analgesic influence, attentive care brings counterbalance, and patient participation creates partnership. What's really striking in Good's framework is that none of these outcomes is sufficient on its own. Balance only emerges when all three converge, reinforcing each other in a dynamic system. If pain relief is strong, but side effects are uncontrolled, the patient ends up miserable and safety is compromised. If side effects are minimal but pain remains high, recovery is delayed and trust erodes. Even when both domains are managed, neglecting patient participation undermines the therapeutic alliance. In this sense, Good's theory highlights an important truth. Balance is not additive but synergistic. The interaction of the three domains produces a state of harmony that really exceeds the capacity of any single intervention. This integration also underscores the role of the nurse as both clinician and coordinator. Nurses do not simply deliver medication, monitor vitals, or provide education in isolation. They weave these actions together into a coherent whole, continuously recalibrating the equilibrium between relief, safety, and satisfaction. The fragility of this balance makes it not just a clinical challenge, but an ethical imperative as well. Patients, you see, rely on nurses not only for their technical skill, but for orchestrating care into a sustainable, human-centered harmony. Good's theory provides more than abstract philosophy. It is a practical framework for the everyday work of nursing. It serves as a reminder to clinicians that pain can't be treated in isolation. Anticipating and managing side effects is just as important as administering analgesics, and inviting patients into decision-making is as crucial as monitoring vital signs. Non-pharmacologic methods, which were once considered ancillary, are now legitimized as central strategies within a balanced model of care. The implications are far-reaching. First, the theory shifts the measure of success away from unrealistic goals of zero pain toward the more humane standard of balance. Pain low enough to permit healing, side effects kept within tolerable bounds, and satisfaction preserved through partnership. Second, it reinforces the centrality of nursing judgment. Because equilibrium is dynamic, nurses must continually reassess, educate, and adapt in response to the patient's evolving needs. Third, it positions nursing not as reactive but as proactive, anticipating imbalance before it occurs and engaging patients as collaborators in prevention. In this sense, goods theory captures the essence of nursing itself. It recognizes that care is never static, but always a matter of harmonizing competing needs in real time. Balance, then, is not just a theoretical construct, but a lived responsibility. It guides nurses to see themselves not only as providers of interventions, but as guardians of equilibrium, professionals tasked with maintaining the delicate harmony that allows patients to feel safe, recover effectively, and preserve dignity in the midst of pain.